everyone. Welcome to this DARA2 conference. At the outset, I would like to thank Dr. Chip Chambers for this very kind invitation and for the privilege to be the opening speaker for this very exciting conference. I bring you greetings from Chandigarh. Chandigarh is a city which is 200 miles north of New Delhi, the Indian capital. Chandigarh was planned by the French architect Louis Corbusier, and it is known as the City Beautiful. It is at the foothill of the Himalayas, and we have a very beautiful lake, and we have a rock garden and a rose garden. And I wish that in future, we are able to host you during one of the vasculitis meetings that we hold. This is the institute that I work at. This is Postgraduate Institute of Medical Education and Research, Chandigarh. This has been declared as the Institute of National Importance by an act of Indian Parliament. The data that I'm sharing with you has been collected over the last 3 years, starting off from April 2017. And besides Chandigarh, it was collected from various different centers all across India. As you can see, Northern India, Delhi, Jaipur, and Lucknow, and from the Central India, Indore, from the Western India, Mumbai, and down south, Hyderabad, Bangalore, Puducherry, and Vellore. And there were other collaborators also, which contributed with patient referral and patient management. 124 patients were screened, out of which 33 were diagnosed to have DADA2, and they were from 28 unrelated families. The majority patients were from Northern India, but there were patients from Southern India and the Western India also, and there was one patient who was of Syrian origin seen at Hyderabad. Amongst the patients from North and Western India, majority belong to endogamous Agarwal Jain community. As far as the presenting features are concerned, most of our patients had features of systemic vasculitis except an infant who had presentation in the form of pure red cell aplasia. We identified 2 first-degree relatives during the sibling screening. Both of them were asymptomatic at the time of diagnosis, but both had documented skin vasculitis in the past, and one of them had central retinal artery occlusion also in the past. The diagnosis was established either on the basis of ADA2 gene mutation, molecular genetics, or on the basis of ADA2 enzyme levels, or both, in these 33 patients. What was a very important or significant finding in our cohort, which you can see here, are these bars, that we had quite a significant number of patients which were well into their adulthood, and this is strikingly different from what is there in the available literature till now. Consequently, as you can understand, the median age of onset in our patients was 15 years, which is much older than the median age of onset, which is 4 years in the existing literature. So when we compared our cohort with the existing DADA2 cohorts, I would just, these are the few busy slides, but I would just wish to draw your attention that the age of onset of our patients and the age of diagnosis of our patients were much elder as compared to the reported age in all other DADA2 cohorts. And the other thing, we also compared our experience with the large classical polyarteritis nodosa cohort from French vasculitis group of Christian Pennew and Louis Guillain. Expectedly, since DADA2 has more CNS involvement, so was true in our cohort also, where we had higher CNS involvement as compared to the large classical polyarteritis nodosa cohort from the French vasculitis group. Rest of the other manifestations, they are just listed here, were no different, and there were no differences in any of these. We also looked at our data with reference to the age of onset and compared whether the findings in children less than 16 years were different from the adults onset DADA2 in our cohort. And there were no difference in any of the manifestations like skin, neurological involvement, or GI or renal involvement, or other manifestations, except for the fact that children less than 16 years had higher constitutional symptoms and had higher hematological involvement as compared to the patients who were more than 16 years of age. As I had already told you, the neurological involvement was very common in our patients, and the neuroimaging done in our cohort showed that ischemic infarcts, which were mostly lacunar infarcts, were the most common, followed by both ischemia and hemorrhage. Then we had cerebral aneurysms and intracerebral hemorrhage. One unique finding that we had in our cohort was features of posterior reversible encephalopathy syndrome in young girl, I mean, these are the images in which you can see that there was enhancement in the subcortical white matter in the bilateral parietal cortices, in the bilateral basal ganglia, internal and external capsules, and centrum semi-ovale. So these features were suggestive of PRES or posterior reversible encephalopathy syndrome. Abdominal imaging done in our cohort showed organ infarcts in the form of renal infarcts. There was mesenteric ischemia in 4 patients, hepatosplenomegaly, perinephric hematoma in a couple of patients, splenic infarcts, and one unique observation was pancreatic infarct observed in 1 patient. None of our patients had focal nodular hyperplasia or hepatic infarcts or portal hypertension. Vascular aneurysms were noted in 9. And we also had 3 patients having peripheral arterial narrowing on the angiography of the peripheral vessels. So these are the pictures. This was a young girl who had very severe illness. There is a microaneurysm in the pancreas, and you can see the pancreatic infarct here. And this patient also had renal infarct. This was a young girl who, despite she had a very turbulent course and succumbed to her illness. She was given high doses of anti-TNFs, and then in hospital, she developed sepsis and died. This is another patient who had mesenteric ischemia and also had features of intestinal obstruction. Another CT showing renal infarct in one of the patients. This is a very striking CT angiogram. As you can see, this was studded with microaneurysms all over, all around in the abdominal vessels, and you can see, and also in the intercostal vessels, there were microaneurysms all over. So this was a very, very striking angiographic finding that we had in one of the patients. This is a CT of a young boy who during childhood was diagnosed to have cutaneous polyarteritis nodosa. During his teenage, he developed diffuse alveolar hemorrhage requiring ventilatory support, and he did require high doses of immunosuppression. And this diffuse alveolar hemorrhage was also one of very unique and rare finding in our cohort. This is a CT angiography showing ulnar artery occlusion in one of the young ladies. I will dwell into the details of this patient later on. She had a bad obstetrical history kind of a presentation and had novel mutations. These are colonoscopic images from young girl with severe GI involvement showing colonic ulcers in the rectum and sigmoid colon. Biopsies were done in 23 patients. The most common finding was vasculitis seen in majority, but vasculopathy was also seen in 2 patients. So the spectrum varied from vasculitis to vasculopathy. This is a GI biopsy image showing ulcer and a blood vessel with the vessel wall infiltrated by the inflammatory cells and fibrinoid necrosis. We had another image showing vasculitis and thrombosis of the vessel. The ADA2 enzyme levels done in 20 patients were almost at the level of, they were almost absent rock bottom. And we also did the screening in some of the family members, and we found the 8 family members were in the carrier stage. Genetic analysis was done in 22 patients, 16 homozygous and 6 compound heterozygous. We identified 10 mutations, which are shown here. Out of these, 8 were missense mutations and 2 were splice site mutations. G47R variant was the most common allele seen in 18 patients. We compared whether the findings in the patient who had G47R variant as compared to others was any difference, but there was no difference in this variant where vis-a-vis the others. We also looked at the presentation and outcomes in the patients who were diagnosed to have mutation vis-a-vis those who were diagnosed with ADA2 levels, and there was no difference between those two groups also. Uh, this was one of the unique patients that we diagnosed in 2017. She had bad obstetrical in the history in the form of preeclampsia and preterm delivery in 2007, spontaneous first trimester abortion in 2009, and preeclampsia and preterm delivery again in 2012. Developed a left hemiparesis because of lacunar infarct, then developed a left ulnar occlusion, and subsequently developed non-healing ulcers when she was diagnosed to have DADA2. That was when she was started on biosimilar adalimumab, and she's been doing fine during the last 3 years of follow-up. If you look at the treatment which has been given to our patient, the gray bars show the pre-diagnosis treatment and the orange bars show the post-diagnosis treatment. And as you can see, before the diagnosis, most of the patients had suboptimal therapies of different kinds. But once the diagnosis was established, they were exposed to corticosteroids, and the most important form of therapy was anti-TNF therapy. Amongst the patients who were given, who received anti-TNF, it was offered to all patients. The most common was adalimumab, which was used. This was used in consultation with Chip and colleagues. And the other one followed by from adalimumab was etanercept, and then last was infliximab. But most important thing to note here is that in India, most of the patients have to make an out-of-pocket expense, and the cost of therapy is very important. So it is very important to note that majority of the patients received biosimilar drugs. Coming on to the treatment outcomes, amongst the 25 patients who were started on anti-TNF therapy, 19 achieved remission, 2 had a relapsing disease. I will dwell onto this later on. 3 discontinued therapy and 1 died. 2 discontinued therapy because of financial reasons, and the 3rd discontinued therapy because she had developed tuberculosis. So the ones who stopped therapy, amongst them, 1 developed coronary artery disease requiring angioplasty, and the other developed GI bleed leading to death at 6 months. Amongst the other patients who did not receive anti-TNFs, 2 were asymptomatic, 3 were in remission, and 2 had a relapsing disease, but they could not afford the anti-TNF therapy, and we didn't have follow-up for 1 patient. I want to draw your attention to this patient who has had a challenging course during the illness with us, and she was diagnosed with us in 2017 when she presented with recurrent facial nerve palsy, skin rash, and arterial occlusion. But over the period of time, despite exposure to 4 different anti-TNF drugs, she had a relapsing disease. She developed sensory neural hearing loss, left foot drop, and developed pulmonary tuberculosis when infliximab had to be withheld because of tuberculosis, and then she developed a stroke. Infliximab was restarted, and we are keeping our fingers crossed because we do not know what really we would offer once she had a relapse again. Another child from Pondicherry, that child had a relapse of cutaneous vasculitis and new onset foot drop when the adalimumab biweekly was changed to weekly therapy, and the child is doing fine. We also we knew that CNS manifestations improved, but we also observed that most of the other manifestations also improved with anti-TNF therapy. I could collect some data from 6 other patients. Many of them had the disease diagnosed during their adulthood. And the other important thing to note was that 4 out of these 6 belonged to the Agarwal or Jain community. So I would wish to conclude by saying that we saw the onset and diagnosis was well into the adulthood in our cohort. We also observed, so that is why the adult care providers need to be aware about that. Novel presentations like pancreatic infarct, DH, and PRESS were noted. Biosimilars were effective. The anti-TNFs were the most effective drugs. We have to note that biosimilars were effective, and relapsing disease is a challenge. In the end, I would thank Chip Chambers and DADA2 Foundation for help facilitating the diagnosis and putting me in touch with wonderful friends like Pui Lee. And I would also wish to thank all my collaborators and care providers to our patients. Thank you very much for your patience here.